Good morning everyone. Today we will move on to the one more important nematode, the filarial worms. You all would have heard about the dreaded disease called as filariasis, which has now reduced, but probably about 40 to 50 years back this was a very common disease. Even now it is endemic in some parts of India. So filarial worms, they are nematodes, means all the nematodes, I hope all of you by now know that all the nematodes are called as worms because they have a well defined cavity. They may be monoecious or dioecious. They have a gastrointestinal system. Okay. These nematodes belong to the superfamily Filaroidea. They are transmitted by bite of blood sucking insects and they remain in the blood or the connective tissue. Morphologically, they have a pharynx. I told they have a well developed gastrointestinal tract. They have a muscular portion called as the pharynx, and males will have a well developed alae and spirally sealed tails. Sexually mature females will release microfilaria. Here the nematodes do not release the eggs, they give birth. So they give birth to the larvae. Now medically important filarial worms are Wuchereria bancrofti, Brugia malai, Loa loa. Important filarial worms of less medical importance are Onchocerca volvulus, Manzanella perstans, Manzanella ozardi and Manzanella streptocerca. But what are important are the first three: Brugia malai, Wuchereria bancrofti and Loa loa. Now filariasis is a very common disease in tropical and subtropical countries. Let's move to lymphatic phylariasis caused by Wuchereria bancrofti and Brugia malai. Wuchereria bancrofti. This is also called as, the worm is also called as Filaria bancrofti or Bancroft's filaria. It was first found by Wucherer in Caelus urine, and Bancroft found it in the adult female mosquitoes and described the life cycle. Hence, credit is being given in its nomenclature to both the scientists who worked on it, and it is called as Wuchereria bancrofti. The adult worms reside in the lymphatic vessels and lymph nodes of man, and the larval forms remain in the peripheral blood. Bancroftian filariasis or the lymphatic filariasis is not a zoonotic disease. In India, it is common along the sea coast. Lot of cases are seen in West Bengal, Kerala. We have seen lot of cases there. Coming to the morphology of Wuchereria bancrofti, the larval forms or the embryos are called as microfilaria, and adults, the sexes are separate. Hence, male and female adult worms can be seen. Now, to describe a microfilaria, this microfilaria of Wuchereria bancrofti resides or remains in the peripheral blood. It circulates and it escapes from the lymphatic vessels into the general circulation and remains in the general circulation till it is picked up by the mosquito. When they are unstained, they appear colorless, transparent, like a thread, like a white color thread they will appear. They have rounded heads and pointed tail. They have the nuclei which are like granules spread throughout the microfilaria. Yeah. They have a hyaline sheath which actually represents the chorionic envelope of the egg, and they have subcuticular cells. Somatic cells are also called as nuclei. At 2 to 3 places these nuclei are absent, which are the nerve ring, the anterior and posterior V-spot, which will develop in future as the alimentary canal and the excretory canal. This microfilaria can remain in the circulation for about 2 to 3 months. So, around 70 days is the lifespan. Now coming to the adult worms. The adult male is long hair-like transparent nematode, again like thread, seen in the lymph nodes or the lymphatic vessels, around 4 centimeters in length. The tail end has 2 spicules of unequal length, which helps to hold the female worm during copulation, and it will remain in the lymph nodes or the lymphatic vessels for around 5 to 10 years. The adult female is a long hair-like transparent white thread-like nematode, again around 10 centimeters. So the male is around 4 centimeters and adult is around 10 centimeters. The tail end is narrow and abruptly pointed. It does not have spicules. It is ovoviviparous, means it releases eggs with well developed embryos or larvae, and immediately the larvae come out. Lifespan again is around 5 to 10 years, and it resides in the lymphatic vessels or lymph nodes of humans. Now look at this. This is a microfilaria in the peripheral blood of microfilaria of Wuchereria bancrofti. The last picture is the gravid adult female worm. Look at the pointed end, pointed posterior end and rounded anterior end. Now coming to the life cycle. Microfilariae exhibit nocturnal periodicity. This concept you need to understand. Nocturnal means in the night. Periodicity. So periodically in the night the microfilaria are released into the general circulation. So daytime the microfilaria of different filarial worms are released into general circulation periodically. Wuchereria bancrofti characteristically exhibits nocturnal periodicity, means in the night. So what is that time? Around 10 to 2 am. 10 pm to 2 am is the time when Wuchereria bancrofti releases microfilaria into the general circulation. Whereas Brugia malai is also, it can be day periodicity, or it can be diurnal periodicity, wherein during the day it is more, that is around 2 pm to 6 pm, and nocturnal as well as nocturnal periodicity, which is 10 pm to 2 am in the night. The microfilaria of Wuchereria are always nocturnal, that is in the night they are released. Why this becomes important? When you suspect a case of lymphatic filariasis, and you should always take sample in this period where microfilaria can be expected to be seen, that is 10 pm to 2 am. So midnight sampling of blood for peripheral smear to see microfilaria of Wuchereria bancrofti is based on the fact that the microfilariae they exhibit nocturnal periodicity. Now coming to the life cycle. Life cycle of Wuchereria bancrofti takes place in 2 hosts. The definitive host is only human, and the intermediate host is mosquito belonging to Culex or Aedes. Now, the mosquito, when it bites for a blood meal, it releases L3 larva, and these larvae which are into the circulation, that is where they are deposited due to the mosquito bite, they increase in size and enter in the lymphatics. In the lymphatics they become metamorphosed into adults and remain there, that is around 5 to 10 years. They separate into male and female, and they will remain entangled in the lymph node or the lymphatic vessels. Alright, then what happens? The female starts laying the fertilization occurs in either the lymph nodes or the lymphatics, wherever they are there, and the female starts laying the eggs with mature microfilaria. The microfilaria, once released, immediately enter into the general circulation, and they remain in the general circulation for say around 70 days. Then during this period, if there is mosquito bite, the mosquito will pick up this microfilaria. The microfilaria will shed their sheath. I told they have a hyaline sheath, right? So they shed that sheath and penetrate into the midgut of the mosquito and migrate to the thoracic muscles, where the microfilaria becomes a short stubby structure called as L1 larva. Then this L1 larva in the thoracic muscles molts twice, becomes L2 and L3 larva. Molting means the short stubby structure increases in its length and it becomes L2 larva, then again it becomes L3 larva further by growing, and this L3 larva, which is the infective stage to humans, it migrates to the salivary glands of mosquito, and when the mosquito bites, these L3 larvae are released into the human blood. So this is how the life cycle continues. Now coming to the clinical features. I told you microfilariae are present in the blood and the adult worms are present in lymph nodes or lymphatics. So our clinical features will depend on the injuries caused by these adults and microfilariae. Okay, so the clinical features are mainly lymphedema, lymphangitis and lymphatic phylariasis. So lymphangitis means the inflammation of the lymphatic vessels. Why that inflammation should occur? That's because the adult worms, there are a large number of worms, they remain in the lymphatic vessels and they obstruct the flow of lymph. So what happens? The lymphedema. So the lymph which has to flow back to the heart does not happen and it starts stagnating or collecting due to obstruction by these adult worms. It starts collecting in the lower limbs. So lymphedema is seen. Then lymphadenitis. Lymphadenitis means the lymph nodes enlarge. Invariably it is the inguinal lymph nodes. Inguinal lymph nodes because the adult worms are present in the inguinal nodes and in the lymphatic vessels of lower limbs. Since the backflow of lymph is obstructed and these worms remain in the lymph nodes, the worms whenever they die, they cause a lot of inflammation and the lymphadenitis, enlarged lymph nodes. So lymphangitis, that is inflammation of lymphatic vessels, lymphatic obstruction, lymphadenitis. This over a period of time, this is a chronic disease, around 5 to 10 years it takes for a proper lymphedema to be seen. Okay. Then the last stage is that of lymphatic phylariasis. Okay. During now what happens, what symptoms will the patient have? So during this periods of lymphangitis, that is inflammation of the lymphatic vessels, there will be a periodic attacks of fever with lymphadenitis, the inguinal lymphadenitis, and these fevers will subside. So by the time patient comes to us with a persistent edema of the lower limbs, it is around 2 years. Okay, and permanent dilatation of the lymphatic vessels is seen, which is called as lymphangiovarix, and sometimes the lymphatic vessels will rupture leading to lymph scrotum or chyluria, means the chyle in the urine, or lymphuria or lymphocele can be seen. Then when this continues for a very long period, like 5 to 10 years, then the hyperplasia of the skin and connective tissues occurs. The skin overlying this region, that is the lower limbs, becomes dry, dry, scaly, and that time it is called as elephantiasis. Due to the dryness of the skin and hyperplasia of skin and soft tissue, it may lead to secondary bacterial infections, wherein Streptococcus pyogenes and Staphylococcus aureus are the common organisms. Yeah. Most of the cases may remain asymptomatic, that is very low parasitic load will be there. They will on and off, they may have complaints of fever accompanied by lower limb edema, then with the foot end elevation and all, they will subside. This is asymptomatic filariasis. The symptomatic filariasis may range from inflammatory phase, that is lymphangitis, lymphadenitis, then there is obstruction, then there may be hydrocele or elephantiasis. Involved parts are testicles and epididymis, wherein epididymo-orchitis may be seen. That may be a cause for secondary infertility. Then lymphadenitis, the inguinal lymph nodes are the common ones. Why lymphangitis occurs is due to the mechanical irritation caused by movement of the adult parasites in the lymphatic system. The movement of these adult worms is always opposite to the flow of lymph. The lymph has to flow up, but the movement of the filarial worms is downward. So it is opposite to the flow of lymph. Sometimes there may be a atypical presentation, like look at the picture above wherein it shows an axillary mass, that is actually the axillary lymph node which has enlarged, and the lymph flow to the from the upper limb, the hand and the arm, forearm and the hand is obstructed, hence you can see lymphedema of the upper limb with the lymphadenitis, that is a enlarged lymph node in the axilla. And sometimes see, look at that, lymphangitis of the breast. Yeah, this is a hydrocele. Look at this. This is the last stage of filariasis, which is the elephantiasis. The right leg has undergone chronic filarial changes and it has become elephantiasis. Elephant-like, hypertrophied, hyperplasia of the skin. Skin becomes rough, fissured, and the hair are lost. This is called as elephantiasis. Now, coming to occult filariasis. Occult filariasis means hidden. Here, there won't be any features of lymphatic filariasis, but there will be massive eosinophilia. So, whenever there are so much eosinophils, you must suspect a nematode or a parasitic infection. Generalized lymph node enlargement may be seen, hepatosplenomegaly, pulmonary symptoms, but there are no microfilaria. That time what you have to do, repeat, you might have suspected filariasis, but you are not able to demonstrate the microfilaria. So you have to sample the blood during the night time, that is due to periodic, that is nocturnal periodicity of the microfilaria. This occult filariasis is characterized by weight loss, fever, paroxysmal cough with scanty sputum, but when you see the peripheral smear, lot of eosinophils are present. Okay. Yeah, look at this. This is a peripheral smear showing microfilaria. There are so many microfilaria in the peripheral smear. Now, classical difference between classical filariasis and occult filariasis. See, classical, there will be worms, adults, and in occult microfilaria are more. The lesion in classical filariasis is mainly due to first you will see a granuloma on the skin where there was bite, and whereas occult filariasis, it's only the allergy or the eosinophilic granuloma due to high eosinophils. Then the organs which are involved in classical filariasis are the lymph nodes and the lymphatic vessels, whereas in occult filariasis it is all the visceral organs, the lungs, liver, spleen. Microfilaria are present, are demonstrable in classical filariasis, whereas in occult filariasis we cannot find microfilaria. That is when you should suspect occult filariasis. When you think it is filariasis but you are not able to demonstrate microfilaria, suspect occult filariasis. Okay. Then occult filariasis responds very well to diethyl carbamazine, which is the drug of choice. Now coming to lab diagnosis of filariasis. These can be demonstrated, classified as direct evidences or indirect evidence. Direct evidences means wherein you demonstrate the microfilaria either in blood or chylous fluid or biopsy, or you demonstrate the circulating antigen by a serological method. Indirect means immunological tests, that is, and the blood counts, the CBC, high eosinophilia, all that points towards indirectly you can tell that there could be a parasitic infection. Okay. Now coming to direct evidences, wherein we demonstrate the presence of microfilaria in the blood. This is done by doing a peripheral smear and staining with Leishman stain or any Romanowski stain for that matter. Now microfilaria of Wuchereria bancrofti, I told, will exhibit nocturnal periodicity, so 10 p.m. to 2 a.m. is the best time. If you are not able to demonstrate the microfilaria, then what is done? A Dec Provocation Test is done. Means a small dose around 2 mg per kg body weight DEC is given, and within half an hour blood is taken, large number of microfilaria are released. The moment DEC is given, large number of microfilaria are released from the lymphatics into general circulation, because they don't want, the worm does not want the microfilaria to die. The life cycle has to continue. So they all come into the circulation so that mosquito bites and picks them up for the continuation of the life cycle. But we want the microfilaria in the blood to demonstrate them. So we give DEC and large number of microfilaria will be released. Within 30 minutes we take the sample for peripheral smear. Okay, that is DEC provocation test. We can demonstrate the presence of microfilaria in the chylous fluid as well. Sometimes biopsy specimen in occult phylariasis, liver biopsy or lung biopsy may show microfilaria. Indirect evidences, by showing that antibodies were present, we can tell indirectly, yes, that he has had an parasitic infestation with filarial worms. Then skin test, which is a hypersensitivity test, by giving a small amount of filarial antigen, a huge response, type 1 hypersensitivity will be seen, and eosinophilia is seen in the as a supplementary test. And look at this, FNAC of a lymph node showing the microfilaria. Okay, now coming to prevention and control. Eradication of the vector is very important, education of the people and protection from bites. Eradication of vector can be done by chemical or biological methods, wherein a type of oil is sprayed onto the lakes, standing water bodies, so that the mosquitoes do not breed there. And health education to population in this sea coast is very important, informing them about the mosquito bite, how you have to prevent against mosquito bite, all that, and education regarding the symptoms, the early symptoms. Once the patient sees the symptoms early, he probably can be immediately treated with diethyl carbamazine, which is the drug of choice, and protection from bites by using mosquito net has to be encouraged. Okay, so that ends our first class of filariasis, which is Wuchereria bancrofti. So next class I will be dealing with all other filarial worms. Thank you.